Everywhere you look, someone is trying to find a cure for being human. Maybe it's that billionaire chasing immortality, using his teenage son's blood, or the latest health app pinging you at 2 a.m. to say your heartbeat might be irregular. No bother that it just woke you up in the middle of a REM cycle. Also, I recently heard about these massage robots I've been talking about a lot to my friends. They have heated knuckles. That's a thing. Apparently, you have to wear a spacesuit. I'm very invested. Look, the future of medicine is wild and underfunded. But underneath all of the innovation, I think we're asking a more tender question. What does it mean to be cared for? What does a good life look like when healing isn't guaranteed, when there's no clear fix? This is Everything Happens, and I'm Kate Bowler. Welcome back. It's a brand new season of Everything Happens. I've missed you. To kick us off, we're partnered with the Aspen Ideas Festival, a place of high altitude and high-minded ideas. I got to talk with someone I have admired basically forever, Dr. Atul Gawande. Dr. Gawande is a brilliant surgeon and amazing writer and a public health leader who understands better than most how to sit with the fragility of life without turning away. Most recently, he served as the Assistant Administrator for Global Health at USAID. He's been a practicing surgeon at Brigham and Women's Hospital, as well as a professor at Harvard Medical School. You probably know him for his book, Being Mortal. Man, that book changed how I thought about illness and care and what we really owe each other when we face uncertainty. Atul and I talked about so many things, big and small, existential and ridiculous. We talked about what doctors miss, what patients wish they could say out loud, why the best medical advice sometimes sounds a lot like, how much ice cream would still make life meaningful? So if you've ever wondered how to live when the fixes run out, or what it means to feel truly cared for, this one is for you. Welcome. Thank you for doing this with me.
I'm very glad to be here.
I wonder if I could bring you back to Being Mortal, because I have really thought about that book so much since I met you. You captured the tension between medicine's desire to cure and the hard limitation of human finitude. What do you think? How do you see that conflict playing out in modern medicine?
Well, I mean, it played out in me, right? I loved. I went into surgery. I became primarily a cancer surgeon, and I loved being able to go in, join with people in difficult moment, need to solve a problem for them and fix it.
Yeah.
And I fixed a lot of people, but I did not really recognize how much of my practice was going to be about working with people on problems that we weren't going to be able to fix.
Yeah.
That might have been terminal illnesses, serious illnesses where major impairment would be an outcome, uncertain illnesses, and then chronic diseases. And it was really a combination of over and over again feeling incompetent at what does it mean, what does it mean for me to be a good doctor? And then also what does it mean for me to be a good son, as my dad navigated, also a surgeon. He navigated a tumor in his brainstem and spinal cord that would take his life. So I talked to more than 200 families and patients who were dealing with often terminal conditions. And then scores of experts, and started to be able to understand what it really does mean to be competent
Yeah.
and eventually feel really effective in these spaces.
And feeling competent, it sounds like, is having a higher capacity for uncertainty in the moment after you can't be the person coming into the room with a solution.
It really boiled down to a very simple thing that I wish I'd understood from the beginning.
Yeah.
Everybody has priorities in their lives besides just living longer.
Yeah.
Those priorities are different from person to person, and they change over time. Your most effective way to learn people's priorities is to ask them. And we don't ask.
Yeah.
I'd say less than a quarter, not just I'd say, I ultimately measured it, less than a quarter of the time, do clinicians or families ask, what are your priorities
Yeah.
besides living longer? When you don't ask, that means your caregiving is often out of alignment with what
Yeah.
matters most to people. And the result of that is suffering. I mean, it's not as simple as saying what matters to you.
No.
You have to be able to have the right kind of conversation.
Yeah.
There was a palliative care doctor named Susan Block who really helped me frame this the best. And what she pointed out is that it's a basic conversation with a couple of key points to it. Number one is just asking, what's your understanding of where you are with your crisis, with your health, whatever the situation might be. Um, and then asking some questions. Well, what are your hopes and fears if it gets worse?
Yeah.
What are you willing to sacrifice and what are you not willing to sacrifice for the sake of more time? What's the minimum quality of life you'd find acceptable? Um, she told me about taking care of her own father. Her father said to her, minimum quality of life. Well, if I can eat chocolate ice cream and watch football on television, that'd be good enough for me.
Yeah. Yeah.
She was like, this is the best living will ever.
Yes.
This is not, do I want chest compressions? Do I want this? Do I want that? What is the goal? Well, if I can eat chocolate ice cream and watch football on television,
Yes.
keep me going.
Yes.
If I can't, let me go.
Yeah.
And I said to my dad, like, hey, this guy said football on television, chocolate ice cream. That was good enough for him. He goes, no way is that good enough for me. And then we were off to the races. Well, what is?
That's right.
What really matters? And it changed over time as his tumor changed. In the beginning, it was like, what do I need to do to stay a surgeon in the operating room? Like he couldn't imagine an identity
Yeah.
not being a surgeon. And then it reached a point where he became paralyzed in his hand and he couldn't operate anymore. And he had to navigate discovering what's his new identity, what actually makes life worth living for him.
Yes. What is the space after just outcomes language? Like I usually found I felt very lonely after a doctor's appointment when I realized I knew a lot about intended outcomes and I knew a lot about my drugs and I knew a lot about side effects, but I didn't have that little place where I could say, I'm just worried my hands are too tender to play with my kid.
That's so much a part of it, right? So for you, it wasn't chocolate ice cream and football and television. There was, a patient I had who just was, I just want to hope I can be able to hold my child,
Yeah.
and she was going through chemotherapy, white count dropping, couldn't be infected.
Yeah.
But what are the risks you're willing to take?
Yeah.
And what are the risks you're not willing to take?
That's right.
That's the question that physicians are very uncomfortable having. My mother developed ovarian cancer. She's 88 now, stage 4. And, uh, and she was at the cancer center where I work. We'd done a trial of
Yeah.
training half of the staff in having these conversations and half the staff not, and showed that the ones who had these conversations were more likely to um, a- uh, have plans that were aligned with the goals that people had, that people had lower anxiety, half the level of depression as they came to the end of life. So I, of course, chose someone who'd been through the training.
So absolutely.
And so, she asked my mother, like, what's going to be, what are your worries? What are your fears
Yeah.
about what might happen here? And I thought my mother would say, she had this long black hair to her waist
Yeah.
that seemed to me like part of her identity. It's like, I don't care about that.
Really?
Yeah. She feared, she was living independently in an apartment. She already had a little trouble walking and she feared having a fall and losing her apartment, getting sick in anywhere where she lost her apartment.
Yeah.
Well, it turned out one of the chemotherapies was going to cause a loss of sensation in her feet
Yeah.
over time. And so now the trade-offs, do I do the full chemotherapy or not? And they came to an agreement that they would do the chemotherapy up to the point that it caused that.
Yeah.
Then they would stop it no matter what happens. So we're going to be 6 cycles of chemotherapy, 2 chemotherapies. After cycle 4, at cycle 4, she had a fall.
I see.
She was really starting to not feel her feet. If you don't keep powering through, you don't destroy it, so it can recover. So, so the oncologist said, well, what if we cut it by half? And my mother said, nope, we had a deal.
Yeah.
We're stopping it now.
Yeah.
They stopped the second drug, continued with the first drug, and she took her chances on where that was. That was the risk she was willing to take
Mm.
and talk about. She got lucky. In the end, she's cancer-free now, 4 years in.
Oh,
We know it's not, it's not a curable condition, but, she's doing really well.
yeah. There's something so deeply soulful about hearing people make these lovely, tiny decisions about what makes them feel fully human. There was this example for nursing homes that there could be a very inexpensive intervention that would make people feel more human.
Yeah. A movement that became called the greenhouses, but it started with the idea that everybody in the community would be asked to raise something alive. It might be have a plant, but most of all, it was having an animal,
Yeah.
right? And people were given parakeets to take care of, or a cat or a
Yeah.
dog, like. And these were this was a nursing home, like severely disabled people, Alzheimer's and so on. But it brought them alive,
Yeah.
gave them a reason for living. They could choose it. And it meant the staff had to be part of the care of a pet,
Yes.
like
Yes.
he's,
Tritos.
like the
Yeah.
cat, the parakeet needs to be fed, etc. But the person who, they are participating as much as they're able to, and in a companionship and in the caring
Yeah.
and the life course of these living things. And, that expanded into the concept of how do you bring purpose into people's lives?
Yeah.
And it's living things. It's also contributing in the ways that people feel they might be able to.
Yeah.
It's taking risks, like, I talked to a woman in her first month in a nursing home, and she'd had a home in Delray Beach, had done well, except that she'd developed such disabling arthritis,
Mm.
congestive heart failure, that she had to give up the home and move up to Boston near her daughter. And they found a safe and a secure place, great ratings. She was miserable.
Ah.
She's assigned to a room, has lost her privacy. She's got a roommate. Her belongings are reduced to what she could have in a cupboard. The schedule is, here's the wake up time, here's the medicine time, here's the activity time. She's like, I used to volunteer at the library. I used to raise flowers. I used to, like, I had purpose. It wasn't bingo
Yeah.
and movies. And, and, and how do I have that? And,
Yes.
she has said, like, her minimum quality of life was having some privacy and some purpose.
Yeah. There's something so strange about I find the volume setting of our pain. It goes down when we start to care for other things.
Yeah. You have some responsibility. You're trusted.
Yeah.
You're trusted to make
That's
choices.
nice. I hadn't thought of that. Yeah.
Yeah. And to take some risks. Have a cocktail.
Totally. I've I was at the Lemur Center for some reason at Duke University. I promise this is going somewhere.
I like it.
Lemurs are very endangered. They're endangered all the time. Too endangered, they might say. So they have to move them to North Carolina. And I was like, what's the best outcome for lemurs? It seems like having more lemurs and you protect them and they survive, and congratulations. So if that's true, why don't you just put them in an ultimately safe environment all the time? Which is like, why even just let people take risks? And then it turns out that everybody, lemurs included, is absolutely miserable if we can't take risks, that we can't find there's this oddly natural expression that, and without it, just I think the volume of our own neuroses, problems, anxieties, we start to malfunction.
I think this becomes the family conflict, right?
Mhm.
You know, grandfather's not taking care of himself. Why is he living in that big home? He's going to break a hip and then it's a disaster. Um, and it's a conversation. You're not totally wrong, but really having the conversation, what are the risks you're willing to take? Can we think about what happens if
Yeah.
this happens? Maybe they just don't want to talk about it. They're feeling controlled, and this is holding important to have the independence. But, you know, in many situations, it can be, all right, we
Let's just,
know the crisis call is going to come.
yeah.
and I'm going to be prepared for it
Yeah.
because we've talked about he's not willing to move his situation, right? And maybe it's an ongoing point of conversation. Maybe you both agree he's got community, he's got other things that make him happy, and he will lose that with the other choices.
Yeah, that's right. I always think of you as like the most human doctor, just like
no.
capital T, capital M. I wonder right now, healthcare included, we're seeing a dramatic renegotiation of what it even means to be human right now. I saw a massage robot the other day where it was heated, so it felt like your knuckles. And now I wonder what hands are for. But I know there's incredible debate right now among especially AI innovators about the future of medicine. But sometimes I feel like they're just saying like, what's the future of being human in healthcare?
I'm having this conversation constantly, and the thing that the tech people have a hard time understanding is healing is not a correct diagnosis and treatment. It's where you start. But in the end, all the AI can do is give you the probabilities. This is the probability that this is your diagnosis. Probably it's another diagnosis.
Yes.
Here's the probability that this treatment will work. What do I do with those probabilities? My wife had a slightly low sodium, and you look it up, and it's like, well, there's a chance it could be an adrenal problem. But what are the chances? Extremely low with a single lab test. Well, what do you do about it? What's your recommendation? Well, that's the conversation we just had, with the risk you're willing to take and not willing to take, how much you want your life disrupted to go through a bunch of testing, everything now, or how about we just wait 3 months and recheck the lab test? And that judgment is what
Yeah.
a clinician interaction is. And we feel it's so empty because most of us in the US don't have a relationship with a caregiver. And I know enough about what's happening in Canada to know that that's also degraded to a significant extent.
Yeah.
And so you don't have that trusting relationship where someone you feel knows you can say, help me navigate the choices here. And if I can, to be a counselor is to understand your goals and the trade-offs and to make a recommendation knowing that. And AI isn't that, right? It's certainly not the human touch and that personal connection.
I hadn't thought of that. We're just sort of multiple choices you. It forces you into an ABC, but you're the one based on a pretty unique constellation of values and context and limitations have to press into that choice. All kinds of people right now who are spending bajillions of dollars in order to attempt to extend their life in dramatic ways. Like someone I met recently who's receiving blood from his son in order to attempt an experiment to extend his own life in a surprising way. And it made me think of you, who has been like pro-limitation, pro-mortality for these many years. So just a quick question, like what's wrong with us?
One of my favorite conversations I've gotten to have was with George Saunders, the fiction writer. And I said, if you could take a pill that can make you live 800 years, would you do it?
Yeah.
He's like, oh man, I've got to live with all these regrets for 800 years. I have a hard time with can I, you wanted to negotiate. Like, how do I, how do I navigate? And I was like, I would totally take the pill. Like if I could have health and purpose, I'm going to want that. So I'm not anti foreverness, but I also know, we have improved the life expectancy. So the top 1% of high income countries can live 90 years on average.
Yeah.
That we've learned enough in public health and in medical care and living how to enable that. That's incredible. That's, more than doubled the human lifespan since the beginning of the 20th century. Now, what hasn't changed is the max lifespan. The oldest person is somewhere around 118, 120 years.
They're Seventh-day Adventist. They only eat vegetables. As a religious historian, I always know, I'm like, certain groups are really going to go the distance.
They might get there. God be with you on extending that lifespan. Worth learning how we do that, but we haven't done that. And we already have the magic of how to get more out of it. And deploying that capability town by town to everybody alive is
Yeah.
what that requires. And that's public health, that's some medical care, and it's, you know, a certain set of things around your environment and your connection to the world.
Yeah.
So, yes, there are people looking for the magic elixir in a blood transfusion and everything else. And a war will change everything, or a terrible car accident, or a bolt out of the blue out of nowhere. Half the heart attacks happen, with no warning indication whatsoever.
Yeah. You have a dream for public health, and it's really quite straightforward.
Well, I led global health at USAID,
Yes.
and which is going through terrible travails and with incredible cost to life. But what I got to see leading health teams in 65 countries, touching hundreds of millions of people and saving enormous numbers of lives, was some countries that are seeing extraordinary results. And so my big idea was a medical innovation that, for example, in Costa Rica in recent years has lifted their life expectancy on average in the country to 82 years, um, which matches the second longest lifespan in all of the Americas.
82 years.
We're only 78 years
Holy
in the
crap.
United States.
Yeah.
Um, and in Thailand, they deployed this medical innovation, um, and took their death rates from where they only had a 65-year life expectancy to now almost matching ours with $300 per person per year for
$300.
their entire health system.
And ours is bananas, right?
Ours is $14,600 per person per year last year.
Okay.
Yeah.
Okay.
So what is this miracle drug?
Yeah.
This innovation is simply community-based primary healthcare. Primary healthcare that serves some key functions. Everybody is assigned to a primary healthcare team. So you have a default team. You can choose one. If you don't like it, you can go get somebody else, but you've got a default team that is yours. To see that team for the majority of your medical needs, whether it's acute care, chronic care, prevention,
Yeah.
it's either free or very minimal cost.
Yeah.
And also for the essential medicines that keep you alive, and for tests. Thirdly, there is a community health outreach worker who's part of the team, who visits every home, makes a contact point with every family at least once every 3 months. And, in many of the places, they're taking a heightened weight of the children to see if they're malnourished, or they're taking a blood pressure to see if hypertension's under control. Depends on what the most risky issues are in that community. And finally, they set a goal that for the big killers, it might be cardiovascular disease, and therefore it's high blood pressure control and diabetes. It might be addiction. It might be childhood death. They're going to make sure that you're offered the right care. You're not waiting for people to come in, because often it's too late.
My friend Ari Johnson called it the violence of delay.
The violence.
I thought that was lovely.
Well, we have one of the weakest primary care systems in the world. We have some of the best secondary and advanced care in the world. So when you're finally sick, but the average American has a $2,500 deductible.
Yes.
Before they can go in and see a clinician for their problem. So they're not going in until it's a crisis. Yeah. And, there are basic things we can do to move towards that direction. It will get us far better results for what we get for our current level of expenditure.
And these could just be community centers.
The way I would put it is, first of all, you need to have a primary care team.
It's already such a big step for almost everyone I know who doesn't have a GP that they have been in contact with forever and they can't get one.
That's right. So we have a huge supply problem, in part because we train, over 90% specialists. And here I am, I'm a specialist, right? A cancer surgeon. But the foundation of your system has to be a front door that actually works.
Yeah.
And it's not going to be just an app. It needs to be a team that can, address your issues. And we don't pay those teams. They're the lowest paid teams in the country. So It's partly improving the pay. It's also recognizing that they only get paid for visiting.
I see.
Every time you make a visit to the office, they get paid. They don't get paid for a phone call. They don't get paid for an email. They don't get paid for being in contact with you or having the office make sure, to follow up on your high blood pressure and how that's going. We have to pay
Yes.
for that. And that's
So
called
it's a,
capitation. It's like,
yeah.
it's a flat payment. That's how we pay concierge doctors. So it's basically, it's concierge care for all, which sounds impossible,
Uh-huh.
but there are places all over the world that are making it work at
Yes.
far less money than we're spending.
That friend, I met him here, Ari Johnson. He works with maternal health outcomes in Mali.
In Mali, yeah,
And
Muso. It's a great
Luso, and
organization.
it was just, they just hired and trained community women to make house calls. And he was describing, like, at first you're getting all the crises. And then 3 to 5 years in, all of a sudden you've got so much trust and history that you're fixing. I mean, you've got prevention, you've got anticipation of people's needs, and then it's so much, and just frankly, like, cheaper at that level. Not only is it deeply humane.
Yeah. Well, a couple of things. I mean, first of all, if they knock on every door, a quarter of the doors don't want to open. They're like, who are you? Stay out of my life. Do I want to tell you about my HIV? No,
Yeah.
not your business. But then it's someone in your neighborhood, and then you have an issue.
Yeah.
And there's someone who's been knocking on the door, and now you open the door and you say, well, I do have this question.
Yes.
I can't get my medicines, or, you know, we're having trouble with whatever the issue might be.
Yes.
And that dramatic, demonstrably improves the outcome. It might be that they just had a baby and they have questions, all of those things.
Yeah.
And you connect them into the system. So they're not
Yeah.
disconnected and unfamiliar. And the lives that get saved are especially younger people, because many people, as you get older, have contact points with the system.
Huh.
Some of the biggest beneficiaries, for example, of just getting Medicaid coverage are people in their 20s and 30s who
Right.
may not touch the system
Yeah.
for 10 years. Adding in that you've got it might be a community nurse, it might be a ordinary health worker touching base with you, gets dramatic results. How do I know? COVID, we couldn't get to 95% vaccination of the elderly and at-risk, highest risk population until in the communities with low levels of vaccination, you hired local community health workers. We hired 150,000 who went door to door and knocked. And all they did was offer, do you want a vaccine? And Republican, Democrat got 95% vaccination
Oh my God.
because they were simply connected into the system
Yes.
and offered a way to make it happen, because this is an impossible system to navigate.
Yes. Yes.
And then we fired them.
Yes. Will you tell me about your job at USAID? It was enormous. I just want to give people a sense of the scope.
Yeah, I mean, it was an amazing job. I describe it as the best job in medicine I've ever had. That, in fact, it's the best job in medicine you've never heard of. It was 2,500 people that I had in 65 countries around the world. We deployed a budget of half of my hospital budget. It was basically about $24 per American per year, and we're able to save lives by the millions. It focused on the biggest killers, and this was the team that in the 1980s eradicated smallpox. Today, it's let's end polio. Let's bring a close to HIV as a pandemic, TB, malaria. Strengthen primary healthcare systems, enable outbreak disease response, so they're protecting the homeland from threats from abroad, and enable maternal and child health outcomes. Concentrating at the beginning of life as the critical starting point. And it's where these programs have deployed have had remarkable results. They're accused of being wasteful, and there are things that can be done more efficiently, but $24 per person per year, the tax bill on average in America is about $15,000 per American. This gets extraordinary results, and so there are ways to be even more extraordinary. But come on, let's not. So in a matter of a few weeks, with the new administration coming in, they shut it down, purged the staff, handed out termination notices, and um, cut 86% of the programs and crippled the remaining ones that were left. So, I was in Kenya just last month looking at the consequences. The estimates are already over 300,000 deaths. And I saw what has happened. I saw it from, uh, you know, we have all but cured death from malnutrition. We now know the ways to address that. And I'm visiting a place that hadn't seen deaths from severe acute malnutrition, because you can know how to refeed appropriately, know how to give plumpy nuts a peanut paste that can rescue, and that paste isn't there. The nurses have been fired. And so seeing that consequences. So we're talking about, just for malnutrition, it's about 60,000 deaths. From diarrhea and pneumonia, it's over 100,000. It's brutal.
Yes. Devastating.
Yeah.
For people who want to keep emotional pace with this as it unfolds, is there something you recommend for people who want to not just know once about the consequence, but know how to stay attuned?
I don't think there's a part of life in the United States, and for many countries abroad, that's not been affected in really significant ways. And one of the most important things we can do is simply bear witness.
Yes, exactly.
There is an attempt to deny the reality of what's happening,
Yes.
and to say, here's what I actually see. That is a starting point.
Is the solution, I mean, the right next step for that, find the journalists that you...
You know what? I think this is actually kitchen table conversations. People around me, didn't know what USAID was.
Yeah.
My mother didn't know what USAID was. And then, they'll say, well, isn't that a criminal enterprise, or isn't that, well, let me tell you what it did.
Yeah.
And I can speak to
So
that.
now that you know, used your trust economy to share that information, because otherwise, if we don't create a critical mass of people who believe, there will be no political will.
It's trust. And it's not the imperfection of people that
Yeah.
it's the tearing apart of our community ties. And so that's why I think so much of this is understanding this is a long run conversation, and building the conversations you have with the people around you. I think the second thing is, if you are in the United States, people don't call their congressman or their senator. It actually makes a difference.
Yeah.
It actually makes a difference. You call the Capitol switchboard, or you just Google the name, and you simply say, I'm against the dismantling uh, of of assistance for global health, or the scientific research that's being done, or the crippling of universities. That that really, it's heard, and it actually matters. And whatever side you are on the issue,
Yeah.
being able to know you have a channel that actually does matter. And this is a long haul project, right?
In the short run, because it just immediately made me want to give more money to like World Vision and like private charities that are doing food assistance right now. Is also just giving more to private charities a good solution right now?
It is. It is really hard for them to have the scale that they had without the support of large government entities that enable this to happen.
Oh, I see.
Just the
So we
level
were
of giving.
interdependent.
Yes, totally interdependent.
I see.
But every dollar does enable them to do things that they otherwise could not do.
Yeah.
And ranges from UNICEF, the World Food Program, Red Cross, there's hundreds of these organizations. The more local you can get, the better. Perry Johnson's work with Muso, in Mali is a great example. Um, and it can be at home too, because there are, the damage that happened abroad, the playbook's been brought home. It's undermining our own vaccines. We're getting measles. We're seeing HIV not only returning and starting to go in the wrong direction abroad. We're seeing that at home as prevention programs get slashed. So, this is, to go back to the beginning of our conversation. I had a chance to talk at Harvard to all of our alumni. It was 9,000 people showed up for commencement. And what I talked about was the conversations I was having about, what are your priorities for your serious illness, has become, what are your priorities in crisis now? In each of our walks of life, we become affected as often crazy changes get made.
Yes.
And then the question is, as your life gets disrupted, what are you willing to endure? What are you not willing to endure? I'm having, I have thousands of people at USAID who've lost their jobs. So they're asking themselves the kind of question, like, the whole field of global health has been decimated. I have to go on and
Yeah.
make a living for my family. What are we willing to do? What are we not willing to do? How do I do things that have the kind of joy and impact that they were providing before?
Yes. Okay, and there's my last question then, because then it'll be about joy. Joy is inherently, deeply, painfully hopeful. It just makes being joyful points us toward the future. What thing, big or small, is making you joyful right now?
Ironically, it's these kinds of situations. I feel very purposeful in crisis, right?
Yes.
um, Things don't have to be perfect, but I do have to find ways that I can feel effective. At the moment, though, I'm actually not in the operating room because I feel like there's things I can do across the kinds of attacks that are happening now, but also looking forward to ways we can make health better. We started to talk about primary care and other things. And those are where I'm getting my joy from right now the most, because it feels like they're
Yeah.
my unique contribution, or a way that I'm doing something that hopefully is additive.
Yeah. You make me want to be a purpose machine, Atul. But this is a really big moment to be a witness. That's my great hope for doctoring and compassionate people everywhere is we just stay put and be a witness. So thank you so much for doing that with me today. This was a true honor.
Isn't he wonderful? Yeah. Well, Atul has this way of reminding us that our mortality is not a problem to be solved. It is something to honor. And maybe the point isn't that we live forever, but to live on purpose. To say out loud, this is what I want, this is what I'm scared of, this is what makes life still feel like mine. So, just in case that's a feeling you need to bless, here is a blessing for ones who are deeply, inconveniently, gloriously human. A blessing for the mortals. Blessed are you who have made peace with the fact that your body is a slightly glitchy miracle. You, with all of your pill organizers and all your hopes, with your deep longings to be known not by your scans, but by what makes you laugh and what you'd risk everything to hold on to. May your quality of life include excellent snacks and naps, and someone who knows how to ask the right questions at the right time. And may you feel deep in your bones that your soft, mortal, limited self is worthy of great, great love. All right, look, darlings, you can find more blessings and reflections and essays and so many feelings at katebowler.substack.com if you are into the whole Substack thing. And if you're feeling generous or even just mildly codependent, if you would leave a review on Apple or Spotify, it ends up being so important for how people find us. It would mean the world. And hey, come find me on YouTube where you can watch every episode. I'm at Kate C. Bowler. Look, Everything Happens is a group project. Everything happens with all these people: Jessica Ritchie, Harriet Putman, Keith Weston, Anne Herring, Haley DeRitt, Megan Crunkleton, Anna Fitzgerald Peterson, Iris Green, and Catherine Smith. A huge thank you to everyone at Aspen Ideas Health, their leadership and staff. They make everything beautiful and all these kinds of conversations possible. This is Everything Happens with me, Kate Bowler.